Good evening, everybody. I would like to say thank you for who is on currently. I'm just going to give the stragglers maybe 1 to 2 minutes to jump on, and then we will start the webinar. So just bear with me and give me a minute or so, and then we will start for you guys. Okay. Thank you everybody again for your time this evening. I know how time poor we are these days, and you guys are all super busy. So thank you very, very much. There are quite a few of you this evening, so you can finish this up and head on to dinner or bed or wherever you're going after this. I know it's going to be a late one, but it's going to be a really good one. So this evening we have two wonderful dentists, Dr. Michael Tang and Dr. Frank Chang, with us. We've got Dr. Michael Tang from Scotland, and Dr. Frank Chang is still in his early afternoon in Perth. And they are presenting on the key success factors showing the breadth of EthOss synthetic bone graft use from pathology and advanced implantology to all on X cases. So you have a wonderful presentation to look forward to this evening. Just give me one. Excellent. Can you still see my slide there? You can see that slide? Wonderful. So EthOss's upcoming events that we have is ANZAP. The first one is the ANZAP in March, 13th to the 15th. So that will be a great event. And then we have the first AOS New South Wales evening on the 1st of April. The next one is new and exciting, and I'll go over that in the next slide, but it's the EthOss Roadshow in Australia in May. And then we have another EthOss New South Wales evening event in June. So we're very excited to let you all know this evening, you're the first, it's hot off the press. We are doing a roadshow to Melbourne, Brisbane and Sydney with EthOss, with our international speaker, Dr. Stuart Kilner from the UK. So save the dates, they're down the bottom. Melbourne is a Monday, the 26th of May. Brisbane is Wednesday, the 28th of May, and Sydney is Friday, the 30th of May. So save the date. There will be limited spots, but if it's anything you go to this year, I would strongly suggest to get a ticket when these go on sale and drop into your email. It's going to be wonderful. A little bit of housekeeping for you guys this evening. You know that we're running a live Q&A this evening with Dr. Frank and Dr. Michael. So please, I encourage you to pop your questions into the chat bar down the bottom, and we will go over your questions live with them this evening. Your CPD certificates will be with you in about 2 days, followed by the recording, which shouldn't be any more than 3. When we do finish our webinar this evening, you will get a very short survey in your email. Please take 2 to 3 seconds, there's not many questions, to fill that in, because your feedback is super important to us. If you want to, you'll have a tick box available to join the EthOss newsletter, and that will keep you up to date with everything that EthOss is doing near and far. So I strongly suggest to tick that as well. And without further ado, I will hand over to Dr. Michael Tang, who will kick us off this evening. So thank you very much. And I look forward to listening to you, gentlemen, this evening. Thank you.
Thank you for the kind introduction, Ashley. And can everyone hear me okay? Yeah? Perfect. So thank you for the kind introduction, and thank you for the invite to work with Frank and also obviously to speak to you all on today's webinar on showcasing ethos in advanced cases. In my daily practice, most of the implants that I place are southern implants, and most of the bone grafting that is carried out is using EthOss. And although I'll be talking about these products, I am not in any way financially affiliated with either company. And what I'll be talking about are simply my experiences and how I use these products for my cases and how they work in my hands. So before we start, I'd like to tell you all a little bit about my background. I qualified in 2002 from the University of Glasgow in Scotland in the UK, and dental implants was one thing in dentistry that really fascinated me. So back in 2004, implant education was limited. I started attending various commercial courses, weekend courses, intensive week-long courses, and so on. Found myself a mentor and started placing implants. Currently, I'm a multi-clinic owner and have several staff working for me. And pre-COVID, I used to travel around 10, 11 different clinics carrying out implants in a peripatetic way. But COVID changed that, and now I only work in one clinic in the city centre of Glasgow. And as well as clinical practice, I am also a clinical teacher for one of the MSc programs in the university. And we also run a year-long implant course as part of the Scottish Dental Academy. The format of my part of the webinar is very informal. Frank is the brains here. He'll talk about all the science-based stuff on EthOss. I'll be going over several cases from sinus lifts, immediate placement to full arch treatment, and I'll be showing you how I manage these clinical scenarios. And I feel that's basically the best way to pick up practical tips, especially since we have a lot to cover within such a short time. And as Ashley mentioned, we will allocate time at the end for any questions. So Frank will be covering the science of ethos, so I don't want to step on Frank's toes, but I want to briefly mention why I like using ethos. The key reasons for me are true host bone regeneration. It is not a space maintainer like a lot of other graft materials. It actually becomes bone. It is resorbed, it's fully resorbed over about a year and a half, so no foreign materials remain. And this allows the site to remodel and turn over into new bone over time. So it adapts to loads placed upon it by the dental implant. The product itself is very straightforward to use. I think it's well known now that using something like EthOss, there's no additional collagen membrane required. And of course, it's 100% synthetic. And what that means is it eliminates any potential risk of cross-contamination. In the past, we taught users to add saline to wet the EthOss and then express the excess saline onto a sterile piece of gauze. So this is how I used to teach my delegates how to use EthOss. Loosen the EthOss within the syringe. So we still do that. And, we pumped a lot of saline into the syringe. We didn't really worry about how much saline we put in. We just put a lot in. And I used to pull the syringe back, mix the saline until it's all wet. I would sometimes, of course, put an instrument into the syringe just to mix it really well. But there's always going to be excess because, as I said, we just pumped a lot of saline in. And we expressed the excess out onto the gauze. Now, whilst this did work, it was unpredictable. Okay, I found my results when I started using EthOss about 7-8 years ago. I just found it worked, but sometimes it didn't. So I know the video is quite small, but the consistency there is actually not bad. For how we did it, it's not bad. It's like a paste, and we would apply it, and then of course place the sterile gauze over the site for at least about 3 minutes to set the product. But as I said, I found that my results were unpredictable. So putting a lot of saline into the syringe, mixing it and expressing the excess saline out is in fact, if you like, wrong. Because by mixing too much saline into the syringe, what happens is the calcium sulfate component dissolves, and then we express the excess onto gauze, which means we lose some of the calcium sulfate. Now, what's the significance of that? So we've lost some of what is required for EthOss to set and bind. So the calcium sulfate is required to set and bind. I have had many users ask me why, when they use EthOss, that it doesn't set, or it sometimes sets and sometimes doesn't set. So the reason is we have mixed too much saline, dissolved the calcium sulfate, and expressed the calcium sulfate out of the product. And in addition, there needs to be that 35% calcium sulfate to bioabsorb over 3 to 4 weeks. So you've got the calcium sulfate in the product, it's set, but over about a month, it bioabsorbs, allowing space within the product for EthOss, little holes within the EthOss for vascularization and bone growth. So now what we do is we add a little bit of the EthOss, a little bit of the saline, just the right amount. Now you can do this in various different ways. You can actually put saline in a syringe and drip saline into the syringe until it's the right amount. Many people tell me that they use about 6 or 7 drops. And of course, that depends on the size of the drop. But it's just the right amount. And I still use my handpiece, but I've just perfected how I use that and how much saline I pump into the syringe. And then I mix it in the tube until it's a thick paste. Okay, so no longer do I wet the EthOss excessively and then express the excess saline into gauze. So that's the wrong way to do it. We must make sure that we mix the right amount of saline to create that paste and not express the excess out, because we lose the calcium sulfate. Some of you have also asked whether I use the syringe that EthOss comes in. I do, and in fact, I use it most of the time. But of course, there are other methods of using the EthOss. Some like to express the EthOss out of the syringe into a sterile Dappens dish, and then adding the saline that way. Then you can use an instrument such as a curette to spoon the EthOss to the recipient site. Or some of you have decided to use some sort of carrier like this here to actually pick up the EthOss to express onto the site. Now, the reason why some of you have decided to use these different methods is because the syringe that EthOss comes in, the tip, I think many of you have told me about this, is that the tip is quite large. And using something like this carrier here with a finer tip gives you better control. So there's different options. And, you know, in a large area, in a large defect like this, using EthOss out of the large syringe that it comes in is easy. You've got a large area, there's no fine control required. You just express the whole lot. So the standard large plastic syringe is sufficient. But when you're doing something like that in an immediate placement, you'll have small jump gaps. And many of you have said that the large syringe means that when you express the EthOss, it goes everywhere. So that's where the finer instruments, the curette, to spoon the EthOss into the jump gap, or using a smaller syringe may be beneficial. However, what I do actually, although those different options are available, I've tried them all, I actually still like using the big syringe. And what I tend to do is mix this syringe mix the EthOss to the correct consistency, express a small amount, and then using an instrument such as a curette to gently pack into the jump gap. So it's whatever works for you. If you prefer to use a smaller syringe, that's okay. But I've just, used it so much that the big standard syringe works well for me. So as I mentioned earlier, I have a series of clinical cases which shows you how I use EthOss on a day-to-day basis. In this case, it's a large buccal dehiscence case. We have this upper left canine, which you can see is discolored, and it's discolored because there's some internal resorption. And you'll see the degree of gingival recession there as well. You'll see in a CT scan, there's a lot of buccal bone resorption. There's this internal resorption of this tooth, and a lot of tooth structure loss. So it's unsavable. And as soon as we try to remove the tooth, the natural crown just decoronates, leaving the root intact like that. It's quite a difficult extraction. Decided to raise a flap because I felt there was no buccal plate whatsoever. And you can see here the buccal plate's totally gone, similar to what we see here on a CT scan. Now, the key about using EthOss is degranulation. So it's key to remove any remaining periodontal ligament, any soft tissue, any granulation tissue at the recipient site. Now, you can do that in various different ways. Any sharp instrument, such as a Lucas curette, will be sufficient, but I find these degranulation burrs very, very useful. It's large, like these large diamonds that you put onto your 20-to-1 surgical handpiece. I would use that first in a sweeping motion across the recipient site before then I finish off the cleaning with a curette. So it's key that we make sure that the recipient site is very, very clean for EthOss or in fact any bone graft material to work effectively and predictably. I proceed to insert an implant. As I mentioned at the beginning, I do use Southern implants, and this is a coaxial deep conical implant where you can see this blue carrier is the implant axis, but it has an internal angle correction. So the driver you see here is actually where the prosthetic screw channel is. So we engage the bone in this angle, but we restore the implant in this angle here. So we see a large buccal dehiscence, almost to the full length of the implant. This defect here is self-containing, so although it's a large defect, we find these defects very predictably fixed with using EthOss. So we mix the EthOss as I mentioned earlier. We set the EthOss. In this case, we immediately loaded it with a temporary crown, sutured everything up. And this is 2 weeks. Okay, so look at how well the soft tissue heals. So for those who don't use EthOss at the moment, you'll be, once you start using it, you'll be surprised at how well the soft tissues heal, how biological the EthOss is, and how the soft tissues just love healing over this particular material. In this case, it's a sinus lift case, it's a crestal lift case. Very little bone height. You know, we've got 3 to 4 millimeters across this way. This tooth will be extracted. CBCT was sent to ENT specialist to give an all clear for sinus lift. We raise a full thickness flap, and we use denser drills for a crestal lift using hydrostatic pressure. And again, for those who don't use denser drills, we have a series of different diameters. The drills are used in reverse with a lot of saline. And the combination of using the drills in reverse with the saline pumps, this creates pressure apically. So as you work closer and closer to the sinus membrane, it pushes the membrane upwards. You know, as you can see here, you can see the membrane being raised up. So that's how we decided to use the denser drills in this case. And you can see here we raised the membrane up and we inserted the EthOss into the sinus and placed the implants simultaneously. And you'll see over a period of months it starts to remodel. Okay, and it remodels to real bone. So it's not particularly radio opaque like cow bone or any other xenograft. It looks like real bone. In this case, we did an immediate placement and we used a technique called tenting. Tenting or a dome technique, and we also made some custom healing abutments. So for the tenting technique, we use the 2O PDS sutures. I like to use some Stabilock drills, which is just a amalgam pin drills, and I'll explain what that's for in a moment. And we use these cervical silicone molds to create custom abutments. In this case, we have a failed 2-unit cantilever bridge. There's a core fracture to this tooth. The upper left central incisor was missing for about 10 years, and you can see there's a buccal dip there. There's some horizontal resorption. So we removed the roots, and I decided to raise a flap, and you can see the contour difference here. Again, we degranulated really well before we carried on. We prepped the osteotomy sites. And in this case, I decided to place some EthOss into the jump gap first. So most of the time I placed the implant first and placed the EthOss into the jump gap. In this case, I was experimenting with how well I can put maybe the EthOss into the jump gap first and into the buccal aspect before I place the implants. So again, you see the significant dip around here. So I use the Stabilock drills to create little holes in the buccal plate. I cut little strips of the PDS sutures. The PDS sutures, for those who are unfamiliar, are like thick nylon nylon strips almost. They're very rigid. And I insert one end of the PDS into the one end of the PDS suture into the little hole here. And I flex the other end into the other hole. So you have this dome effect. And I do the same with another PDS suture. So you'll see there's a dome created there. And we then fit the custom healing abutments. There's another angle of the dome. And we place a couple, maybe 2 or 3 different layers of EthOss because it's quite a big defect. And very often, even when there's no defect on a site, I smear some EthOss over because I like the biological response of the soft tissue over the EthOss. Sutured up, and then this is 1 week. If you look at the soft tissue after 1 week, how pink and healthy it looks. Sutures removed, you see some inflammation where the sutures are, but you see nice healing. And at 4 months, you see a nice bulky soft tissue and contour. And you'll see in the CT scans on both sites, the upper right central incisor and the upper left central incisors, very stable. We're starting to regenerate, starting to get that host bone regeneration. So I use EthOss in all different scenarios. This is an immediate molar placement. And typically, if suitable, the way I carry out the molar placements is that I keep the root in place, and I start prepping the osteotomy with the root in place. And that helps me position where my implant will be. It keeps my drilling stable. So I carry on with the prepping until it's complete. So you can see the osteotomy site prepared. And then I would section the roots and remove them individually. And here I've removed the mesial root first, then the distal root. So the 2 roots are removed, and you can see here that the osteotomy site is where I want it to be. Had I removed the roots first, this little septal piece of bone would be in my hands, very difficult to prepare. Therefore, preparing it in the way that I showed you in the previous slides makes it a lot easier. So after thorough degranulation and cleaning out the sockets, the implant is placed. I always do an ISQ check. And I use those silicone molds to create a custom healing abutment. EthOss is then placed around the implant and the healing standard healing abutment. So I make sure that EthOss is well set. And you can see once I've removed the healing abutment, it doesn't collapse because it's set. And then we place the custom healing abutment. So quite a lot of EthOss used in the past few slides, but used in different ways. All very, very predictable ways of using EthOss, providing the material is mixed properly and not with excess saline. So we also use EthOss in full arch cases. So here we have an edentulous upper arch. And once we've raised the flap, the arch is very, very thin, especially in the anterior region. I do use a lot of guided surgery. So in this case, this is a surgical system that we co-developed with Southern. And it's a carbon reinforced guide, a carbon fiber reinforced guide. We use the lower teeth, the opposing teeth, to help seat the guide in place. And you can see here there's fixation holes. And we use these fixation pins to hold the carbon fiber base in position. So once it's in position like so, this acts as a base where we can actually stack multiple different guides on top, such as the osteotomy guide. So this is now connected, and we can actually drill exactly as we planned and place the implants exactly as we planned. Implants are in place. You can see the southern implants, little carriers poking out. And the ridge is thin, but you can see with the guided system that we use, the implants are placed in the positions that we desired. Multi-unit abutments are connected with the temporary cylinders. The temporary prosthesis is pre-designed and pre-milled, and they'll be used, this temporary prosthesis will be used to pick up the temporary cylinders using an acrylic. So this is polished up chair side. And that's when we can use, before we switch it up, we can use the EthOss in the way that we described. We get it, we're mixed up to this thick paste consistency. It's quite a large area. It's a full arch. So what I tend to do is I apply it on one side first. So I don't apply it to the whole area. So I apply it just this one side first. And whilst one side is setting, we apply the EthOss to the other side. And you can see it's a thick paste. It's not droopy, it's not wet. It actually holds its shape quite well when you mix it to the right consistency, like a thick paste. And once we add we do this in more than one layer. Quite often in big defects, we apply it in multiple layers. So there's a couple of layers to the left, a couple of layers to the right, until the right shape and the correct contour is desired before we suture up. And this is immediately loaded with the pre-milled temporary bridge for the upper. We did the lower bridge at a separate time. In another case, another full arch case, this is a failing upper arch case. So these had deep pockets. Patient had been wearing a denture for a long time. And this is a staged approach. We did grafting first and implant insertion several months later. So you'll see here in the CT scan, the ridge is very narrow, okay? And it's exactly what we see when we raise the flap. Very narrow ridge. So the first stage is grafting. Let's try and get this area here bulked up. So the key thing is, as we mentioned, is once we raise the flap, is degranulation. So these burrs we use in a sweeping motion. We don't lean hard on the bone. We don't want to damage the bone, but we gently sweep these burrs across, and you'll see soft tissue almost like ruffling up. It's almost as if it creates soft tissue. You don't see you don't see any remnants of granulation tissue, periodontal ligament, periosteum, or whatever. But once you start using these burrs, you'll start to see the soft tissue ruffling up. And then you would use sharp instruments. And in this case, I used a bone scraper to actually try and remove any remaining soft tissue. And we mix the EthOss, as I explained earlier, in the syringe itself until it's a thick paste consistency. And once it's the correct consistency, we then start applying the EthOss. As you can see, it doesn't slump. Okay, it holds its shape. You can start molding it to the recipient sites. And one of the reasons we did a staged approach in keeping these teeth in place is to keep the buccal contour, by keeping these posterior teeth in place. This helps the EthOss to be somewhat maintained within the bony envelope. And again, because it's such a large defect, we set one side, and whilst one side is setting, we apply the same. We apply the EthOss to the other side. And we start building this up in layers. Okay, so once this side is set, we move on to the other side. And we keep going left and right until we have that desired correction obtained. So this happens over, I think in this case, there was about 3 layers on each side until I was happy that this contour has been corrected. We don't need to over contour. That's not what we use EthOss for. But just to get the right amount is perfect. So we sutured up and we left it for 4 months. And the new CT scan is taken. And you'll see here a nice contoured buccal anterior maxilla. And when we raise the flap 4 or 5 months later, you'll see here the contour is completely different. It's much thicker. And you'll see here the EthOss is still there. You know, some people say that, you know, we do grafting with EthOss and we go back in several months later and it's disappeared. As I mentioned, it disappears for a few reasons, but when used correctly, mixed correctly in the correct situation, it stays. And you can see how it bleeds. And it bleeds because it's becoming bone, it's becoming real bone. Again, in this case, we use the same carbon fiber reinforced guides. That's the seating jig that we seat over the remaining teeth at the back. And once we've positioned the guide over these teeth, we use the fixation pins to fix the base plate, the fixation base. And now this base acts as the guide for all the other suprastructures that stack on top, such as the drilling guide, which we drill through, of course, using the Southern Implants Cyril guided system. And again, although the ridge is still, you know, it's not exactly an abundantly massive ridge, the implants are placed exactly the way we want them. The pre-designed, pre-milled bridge is put in place, and you can tell that the implants have been put in the correct position because these holes were predetermined, and you can see these temporary cylinders coming out exactly where we want them. So once we've picked up the temporary cylinders within the temporary bridge using a self-cured acrylic, we then polish this up and finish off this bridge. And in this case, we decided to use a little bit more EthOss over the buccal aspects of where we place the implants before we suture up and load the implants with the temporary bridge. Now, in this case, as you can see, it's an FP1 bridge. So it is possible if, you know, a lot of people tell me when they do full arches, they have to do an FP3. But again, in the right cases, with the right bone grafting, FP1s are possible. And in fact, of course, aesthetically better. Post-op radiograph. In this case, I forgot to mention, but we did also do sinus lifts when we did the anterior grafting for this case. So we did sinus lifts, we did anterior grafting, we did all of these things 4 or 5 months prior to placing the implants. So I hope I've given you a flavor of how I use EthOss and how I manage certain implant cases. Just showing you some of the cases that I do on a day in, day out basis perhaps gives you a flavor, an indication of how EthOss can be used and how predictable it can be. A lot of new users especially tell me that they are scared of using EthOss in certain scenarios because they think it won't work. Well, I've shown you a very big mix of different scenarios, which are all very predictable in my hands. So it's down to many things. The product itself works very well, but it's how the product is used, how it's mixed, how it's applied, um, and how the recipient site is prepared is very, very important. At the end of the webinar, once Frank's finished, we do have time to answer any questions that you guys might have. So I am going to pass you over to Frank.
All right. Thank you, Michael. That was an excellent talk and excellent cases they have shown us. Thank you, Ashley, for inviting me to join Dr. Tang on this webinar. My name is Frank Chang. I'm an oral maxillofacial surgeon based in Perth in Western Australia. I'm going to be talking a little bit about EthOss and other different applications and show some cases. In Perth, I work at the Royal Perth Hospital, Fiona Stanley Hospital, and do a bit of teaching at the university, students and our maxillofacial trainees. And so I use this product in private practice and also in the in my public practice as well. So I'm going to talk about applications of EthOss in different situations, and I'll start off by just talking about a little bit about EthOss. It's an alloplastic bone graft material made of synthetic or artificial material, and it is a bioactive material as they have the ability to elicit controlled action and reaction to the host tissue environment with a controlled breakdown and resorption, and ultimately replaced by the patient's own regenerated bone. And in this material, it is a combination of a bioactive beta-tricalcium phosphate and calcium sulfate. And the importance of these two mixture is that the calcium sulfate in situ has a self-hardening property, which means that there's no need for a membrane, a xenograft membrane. And the hardening nature of this material binds directly to the host bone and maintains the space and shape of the graft site and act as a scaffold and prevents early stage of invasion of unwanted soft tissue cells into the graft site. Calcium sulfate is also a bacteriostatic material which prevents an infection. The calcium sulfate part of the EthOss will resorb over 3 to 6 weeks, and it creates vascular porosity in the beta-tricalcium phosphate scaffold. So you can see that these two materials work together in a way that allows the natural regeneration of bone to happen, and also the blood supply to provide the background material to form bone. The beta-tricalcium phosphate is resorbed by the mechanism of hydrolysis over a period of 9 to 18 months. And the whole material is fully resorbable with no long-term presence of residual graft particle. It is considered as a osteoconductive and osteoinductive. However, the osteoinductive is in a way that it promotes proliferation and differentiation of the host endothelial cells and differentiation of mesenchymal cells into osteoblast cells. And so its resorption is cell-mediated, enzymatic, and phagocytic process. And so this is how the material interacts with the host in forming and generating new bone. So here we're going to, in a minute, be showcasing some of the cases, but the importance of selection of graft material, we need to consider tissue viability, the defect size, the graft size, shape, and volume, and the biomechanical and biological characteristics, and how the graft handling properties, some graft are easy to handle, some are not. So you also want to have a nice handling of the graft material for the sake of easy application. And then ethical issues surrounding graft materials. This involves like allograft and things like that. So, you choose something that is that can be used in sort of all age groups, and the right material for that application. Also, you need to consider associated complications of each graft material, and then health economics, the cost of the material that you'll be using as well. So in the day-to-day application of EthOss for me is around implants. So EthOss is used in a big way around implants. So here I'm going to show you some of the standard EthOss applications around implants. Here you have an immediate implant at the tooth central incisor. And so this is a southern implant coaxis where the tooth was extracted and implant was placed immediately, and the EthOss was used to fill those gaps around the implant. So here is the close-up of the EthOss. So it's applied around the implant. You can see it's covering the defect, if you look at the third picture from the left. And this is covered up and also augmented buccal bone, and then finally a primary closure for a staged procedure. The way I use the EthOss in these sort of situation is that I don't use them out of a syringe like Dr. Tang, but however, he did mention that some people use it out of the syringe, and that's what I use. What I do, I mix them out in a dish so that I add in saline and I make it to a consistency that I like to handle with. And so I can pick it up and pack it into a cavity or around the implant. So it's EthOss around the implant now. So you mold it around the implant. And the trick here is to dry it up with a gauze. And you're going to hold it there for about 2 minutes. And allow it to set. I'm not sure if you can hear the video with the gauze. So that was just the EthOss around the implant. Let me just bring up a yeah. So this is after when it's dried up with the gauze, it should start to set, and you would let it set for about 2 or 3 minutes before closure. Okay, so we'll use the gauze to dry up the EthOss and allow it to set. Usually it's about 2 to 3 minutes. And once it's set, after 2 to 3 minutes, you can actually use an instrument and have a feel, the feel of the hardness. And then once you know it's set, you can close the wound. This after. Then here another implant case. Okay, again in the incisor area. Another coaxis implant, and then EthOss over the buccal bone, and here it is. And then once it's done, primary closure as well as a staged procedure. Next case here is a patient who's only got 3 teeth left, so there is some immediate implant. And she also has a trophic maxilla, so 2 zygomatic implants at the same time as 4 anterior axial implant. And so in this case, as Dr. Tang described with his full arch cases, I use EthOss to fill in all the defects around the immediate placed implant, and also around the buccal area to give that augmented buccal bone around the implants, and also around the zygomatic implant defects here. Okay. So here I've shown you EthOss application in a single tooth and to a full arch and immediate placement of implants. So these are my common uses of EthOss from a day-to-day application. Here is a case where I did an extraction of the molar. I use EthOss as a socket preservation in preparation for implants in the future. So you can use it for socket preservation as well. And then when you re-enter, you'll get host bone formation for placement of the implant. In this application here, it's a upper wisdom teeth removal. However, the tooth has caused a bit of periodontal defect of the tooth adjacent of the second upper right second molar. So EthOss was used to repair this defect and graft it into this area to help with bone regeneration, and so that they don't get a pocket behind the tooth, the second molar tooth. Okay, so we went from implant to socket preservation, and now to a bit of periodontal defect. The next one is a case where patient had bilateral ectopic palatal canine, which required removal, and as part of the removal, the canines were very impacted. So bone removal and removal tool was required, which result in a large defect. Patients going for orthodontic treatment at some point, and therefore the EthOss grafting and can enhance and regenerate bone faster, prevents soft tissue ingress into these defects. And so in this slide here, you can see the upper right ectopic canine, and this is the upper left after removal. And over here, you can see the EthOss has been placed into the defect on the right side and has been allowed to set. Then we're going to move on to pathology. So cystic lesions. So what I've been finding is that some of the benign cystic lesions, especially from a periodontally caused cyst or granulomas, the problem with enucleating them and cleaning them up is surveillance in the future. You know, whether there is a recurrent cyst that has formed, or is it a soft tissue ingress? And so when you do the surveillance x-rays, it shows that there hasn't been any bone regeneration. And so sometimes the endodontist will think, oh, is there a recurrent cyst in this area? And then you get a CT scan, and then the CT scan, this is the before the surgery, and then here it's a close-up. Here on the right side, you can see it's immediate after treatment, and so 2023. And then here is a surveillance CT, because the referring endodontist said, oh, on the PA it shows there's still a lucency there. So repeat a scan in 2024. This is a CT scan. So, you know, what's going on here? Is there a recurrent problem? Is there a soft tissue growing in? There's no bone regeneration. So in a benign pathology, a grafting like this may facilitate or help with a future surveillance. So in this slide, oops, here it's demonstrating what I do with the EthOss. So I open up the cap and I put it in a little dish, just like the one I've shown you before. And again, I add saline and I start mixing to the consistency required. And that gives me better control, so that I don't inject a whole syringe into a defect and then try to pack it. With this technique, I'm able to pick up the material and I pack it from the deep end of the cavity, because we don't open up the whole cavity. We go through the dehiscence of the defect, and so we don't lose more bone by removing them, so that you can apply it with the EthOss pen. This way, you can avoid opening up the cavity, mix it up, and pick up the amount you need, and you start from the deeper surface. So this is a granuloma involved with the upper left incisor, 15-year-old patient, previous dental trauma, and had a root canal completed and referred for cleanup and debridement of the granuloma. So it's a beta tricalcium phosphate, calcium sulfate, which means it's a mineral. So using it on a growing child or a pediatric cohort patient could mean that it's pretty safe. So here I use quite a few in these age group. I looked at product safety data for other grafting materials, and I've asked their scientists whether this can be used in growing person, but no one could really give me an answer. However, with this beta tricalcium phosphate calcium sulfate, I feel because it's a mineral, I think it's pretty safe to do so, and the company has also said that they haven't had any report of any issues. So quite a number of cysts that I see. I would put them on inside cavities of benign cysts or benign tumors, purely for a easy surveillance, faster bone regeneration, and reduces confusion in the future. Here, another 14-year-old female who also previously had dental trauma and root canal treatment of the tooth, hasn't resolved the periorbital lesion, so that was surgically enucleated and EthOss placed, and the final primary closure. So another periorbital lesion at the central incisor and concurrent one at the lower right first molar. So these all have been endodontically treated and completed prior to periorbital curettage and enucleation of the cyst. And allow it 3 to 4 months for it to heal. And usually my endodontist will send me a intraoral periorbital radiograph to show the bone formation. And once they're satisfied, they go and have their final restoration completed. In this case, it was a previously enucleated OKC, odontogenic keratocyst. Patient had a recurrence after the previous treatment. Decision was made to go back and re-enucleate and remove the offending tooth. And so once this was completed, EthOss was placed, and on this OPG X-ray, you can see the bone formation, and the previous cystic area has all regenerated in this root area here. Again, another pathological site around the root of the lower left molar, and this was enucleated, like I mentioned before. We just go through the defect or the where the dehiscents were from the lesion, so that we don't have to open up the bone to give access to place the graft. This way you can use a little Mitchell's trimmer or a Lucas curette. You can pick up a little bit of the material, and then you can pack it into the cavity, and you would do so with a bit of pressure. This way you can get a more compact EthOss into the cavity. And I use a Raytech or a gauze, and I go through the access and dry it up as I layer the next part of the EthOss. Here, another granuloma in the lower anterior incisor with a large defect after cleaning. So these are all, I have not removed any bone. These are all dehiscents from the lesion itself. So once you clean up, you can see the defect, and then you're able to pack it all in, and I add a bit more buccal bone, buccal surface to help with the regeneration, and also the contour of the buccal aspect of the mandible. So here is another lesion. So there's lots of lesions in different way of using EthOss. Oops, what happened here? Sorry, I lost my screen. I have to share this again. Give me a second. Sorry, Ashley, can you see my screen now? I just lost that screen.
Yeah, all good.
Yep. Okay, so I can see the enucleation of the lesion. And then once we've done that, we'll go in there. We need to clean it all up. And as Dr. Tang has mentioned before, you need to remove all the soft tissue. Okay, so in this case, I don't use a degranulation burr. I use curette, and I use a round burr just to do a peripheral ostectomy to get the soft tissue out. Any soft tissue that is really adhered to the bone, I use cauterization to remove them. Here's a different application. This is a young patient with impacted lower second premolar bilaterally. So, and they unerupted first premolar. So the request from the orthodontist was to remove the impacted second premolar. And this is an 11-year-old boy. So here, once the tooth was surgically removed through the thick buccal bone, EthOss was used to help with the regeneration. And so they will facilitate healing of the bone and allow progression of the other dentitions through and prepare them for orthodontic treatments. So this is probably one of the youngest patients that I've used EthOss on. And then another large defect here. So again, I don't create the opening. This is where the lesion has perforated through the buccal bone. And so once that's all cleaned up and all the soft tissue has been removed from the cavity, the EthOss is applied and allow it to set. And this was a ridiculous cyst. Again, another cystic lesion associated with central incisor. So this was cleaned up, tooth was removed, and patient wanted an implant. So EthOss was placed in there in preparation for an implant. Action. So in this case, I have used a syringe. And I said that I take out the dish. However, because the cavity was quite large, I was able to use a syringe directly onto the wound. So although you see it was quite bleedy, quite oozy. However, once you place the EthOss into the cavity and you hold your gauze over the bone graft, as it starts to set, it tamponades the bleeding and it still sets hard. And here, another lower incisor lesion where, sorry, not a lesion, this is a supernumerary tooth that was removed, and EthOss was placed here to help enhance the regeneration and bone growth. So that will prevent soft tissue growing in. Another periapical lesion, periapical granuloma, post-root canal treatment, and residual defect here, and EthOss applied, and allow it to set, and then primary closure. Now, in this next case, even though we know that EthOss has a naturally occurring membrane with a calcium sulfate, However, in this case, the grafted area was quite big, and therefore I used a membrane to cover over the EthOss that's underneath here, and then finally a primary closure. One of the reasons of doing this in this instance was that the pathology has come through the soft tissue, so there is a little perforation through the buccal mucosa, and so that buccal mucosa is like a pimple on the gum. You'll see that in some of the infections. You see a little pimple, a little pustule that comes through. So once EthOss went in, I don't want that to sort of leak out through that area or any communication. So a small suture was placed over the defect where the pustule was, and then I've used a membrane to cover it all up as a second barrier. Okay. And so in my last slide here, I like to show the application. So see how I picked them up and apply them a little bit at a time. And you pack it from the deep end. Here, with the gauze or the Raytech, you're able to go in there, pack it in, dry it up, and then the next layer is applied. And once it's all packed in, I place a gauze over the EthOss again to allow the last layer to dry, to set, and then primary closure of the wound. And there it is. So that's how I use EthOss from dental implant to pathology in adult and pediatric population, and socket preservation in preparation for future implants.
Fantastic. Thank you so much. What in-depth, complex, amazing cases you've both shared with us this evening. They were absolutely fantastic. We have had some good questions come through, so we will now, I'll read them out and then I'll leave it for you to fight over who answers them first. The first question is, how hard do you pack EthOss into the defect?
Well, because EthOss, as you can see in Dr. Frank's videos and slides, and some of my slides as well, the EthOss is like a thick paste. So it's not like a hard material. It's definitely not something that you pack, if you like amalgam or even like composite. So you gently almost like use your instruments to mold the EthOss onto the defect. So when we use the word pack, we don't mean, use as much force as possible. For example, in a jump gap where we place some EthOss, you can insert the EthOss into the jump gap and use, for example, a Lucas Correct, and you, in inverted commas, pack. As you pack, you will find that some of the EthOss squish out because it's kind of a soft material, but you do want to try and introduce the EthOss well into the recipient's site, but it's not force. It is a gentle manipulation, if you like, of the material into the area. Would you agree with that, Dr. Frank?
Yeah, I agree. It is a soft paste. So like you said, if you try to squeeze it in, it will come out from the side. And therefore, the way I handle this is I make it into a consistency that's easier to carry and apply to the defect. but I don't just push it in, because even with that consistency, it will still come through the side. So it's just a gentle pressure of the material, and then you can use a broad sort of like a gauze to push on it to allow it to sort of mold and allow it to dry and set. So yeah, no excessive pressure on it, or packing, heavy packing.
Okay. Next question. What speed do you use your degranulation burrs?
Degranulation burrs, I set the speed at about 1,000 to 1,200 on my 20:1 contra-angle surgical handpiece with irrigation. So that's the speed. You do need speed. It needs to be fast. But the important thing is that these burrs are diamonds, so you don't lean excessively at the recipient site because you will remove bone. So it's applying enough pressure on the bone in a sweeping motion to actually, ruffle up and remove as much of the residual, soft tissue, granulation tissue, and periosteum as possible. You will find that the degranulation burrs alone won't remove all the soft tissue. You will need to use separate sharp hand instruments to remove the rest at the end.
Yeah, I agree. I mean, it's like when you use these burr, you're not pressing on the bone, you're sort of bouncing up and down on the soft tissue area, try to get that soft tissue off. And yes, I often use a curette to clean the surface of the bone first, give a good scrape. Sometimes I also use a round burr, just running at the normal speed. You can run it at 80,000 revs. I use Surgitome. And so you don't press onto the bone, you just sort of hover around and just bounce around the bone to get rid of the soft tissue.
Okay, what is the working time for EthOss before it sets? And do you wait for each layer to set before adding new layers?
I'll let you answer first, Dr. Frank.
Yeah, so you can saw my videos. My video speaks for itself. I just pack it in or apply it. Okay, let's not say pack, but apply the EthOss. I dry it up a little bit. I don't wait for it to set, but I keep going with the next lot, and then I allow it to set at the end after you apply the EthOss into the defect or around the implant. And that's when you sort of give it a couple of minutes for the whole thing to settle down and to firm up on the surface. And then, like I said before in the other videos, you use a instrument to give a little scratch to see how hard it is, and that's how I do them.
So in terms of working time, I definitely would not recommend mixing it in advance, leaving it to the sides, and then you work on your site. So definitely have your recipient site prepared, cleaned, degranulated. Then you move on to mix the EthOss, as Dr. Frank suggested, whether in the syringe or on a Dappens dish. Once you've mixed it to the right consistency, I would use it straight away. So it's not a case of, I have 5 minutes, so I'm just going to do something else or whatever. You use it straight away. Now, the question to this, the reason for this question may be that you might be thinking, well, when I use a 1 cc, I can't seem to work quickly enough. I use half the syringe and the other syringe is set, the other half is set. Well, when I use a 1 cc, I don't mix the whole 1 cc at a time. Although I use the syringe, I actually express, once I've mixed the syringe thoroughly, I express half of the syringe into the cap. Okay, so I take the cap off and I express half. So then I've got half cc in the cap and half cc in the syringe. I then use it as if it's two separate lots of EthOss. I mix it till it's the right consistency. I use it straight away on the recipient site. I do actually wait for the first layer that I put on to set first before I apply the second layer. I find it's more predictable in my hands that way because the reason that I use multiple layers is because the defect is bigger. And when the defect is bigger, I want to make sure that each layer is set so that the next layer is sat on a set, first layer, so that I keep building the layers more and more. So I would apply the first layer, set it for 2 or 3 minutes, second layer, set it for 2 or 3 minutes, third layer, set it for 2 or 3 minutes. And as I says, that's the way I find that the layers are actually set thoroughly, and it keeps the contour of the ethos that I've built up.
Excellent. So the next one's a bit of a statement, but probably asking you what you would do in this case. So at socket preservation, you don't achieve primary closure. Some of the graft will still be exposed. I guess they're asking what would you do in that case?
Well, actually, I've left a few of these EthOss cases exposed, and they actually they actually do quite well. Even though they get left exposed, as long as you set it well during the application, you can leave it open to the oral cavity. You might want to overdo it a little bit. Sometimes the first a mil of the top layer may come away, but the rest of the material actually sits quite well being exposed to the oral cavity, and that's how I find it. In some cases, if I can do a primary closure, I would. You just raise a flap and then close over it. But leaving it open in the mouth, I don't see any problems there. Dr. Michael, you feel the same?
Yeah, I do the ridge preservation slightly differently. I don't leave it open. I have many colleagues that do exactly what you're doing, Dr. Frank, with really good results. But I'm just a little bit too scared of leaving the whole lot of EthOss exposed. So I do my ridge preservations in 2 ways using EthOss. One way is I would, put the EthOss into the socket and set it as you would do. But then I put a collagen sponge, just a sterile collagen sponge over the EthOss and suture over it, just so that I know there's something covering it, so that over the next, several days, there's going to be some soft tissue closure, and let that collagen sponge protect the EthOss. The second way I do my ridge preservations is, in fact, I don't do it immediately. I go back in 2 weeks later, all right, once I've had some soft tissue closure, but of course the socket is still there. I then raise a flap because I've got the soft tissue over the socket. I then raise the flap, clean out the socket, EthOss in, and then I close the newly formed soft tissue over, so that I don't need to use a collagen sponge. I prefer it that way. Patients don't, of course. It means that I need to go back in and numb them up again and do a second stage. But I find that works predictably for me.
Excellent. Next question is, do we still need to do the 3-minute wait and gauze press in internal sinus lifts? If yes, how do you do it?
No, we don't do it because it's not possible. So I tend to mix my EthOss. You see, it's EthOss. The way we use EthOss, and way we mix it with saline is a good thing and a bad thing. We talk about how much saline do we use. How much saline we use really depends on individual preference. But to give you an example, for a internal sinus lift case, I would mix the EthOss slightly thicker, slightly drier, so that it keeps its shape a bit more. And the way I do my internal sinus lifts is with those denser drills. I would prepare the diameter of the osteotomy site and obviously lift to a certain level. I then drop down a size. So let's say I've prepped up to 5 millimeters diameter. I would then use my 4 millimeter diameter denser drill in reverse, slow, 50 RPM, no irrigation. And then I would spoon or syringe some of the EthOss into the osteotomy site, into the sinus. And I use the denser drill in reverse with no irrigation slowly to actually reverse and push some of the EthOss into the sinus. It needs to be a slightly drier mix, but no, you do not need to set it for the 3 minutes.
Anything else on that, Frank?
Yeah, I've used EthOss in the indirect crystal sinus lift. You can't dry it through an indirect, like a Summers lift. So you sort of pack it in and allow, and you sort of allow the apical, the coronal portion to set, and the rest just sits in a nice little confined cavity. But in a open lateral wall sinus lift, you can place an EthOss because it has a bigger access. Look, most of the time it's pretty dry. You don't have to sort of set it. You pack it in and you can do a primary closure over it. I don't think you need to, in that case, you don't have to press in that way, but you can. I generally place a gauze pack down to help with the setting or the drying of the material. Keeping it dry, allow it to set. If you have too much liquid or blood around it, it becomes runny again. So I just go through with a gauze pack, go down there and just gently dry it up. Yeah.
Okay. The next question is a targeted question to one of your cases this evening, Dr. Frank. Do you routinely place EthOss in the distal aspect of the lower sevens when extracting impacted lower eights? If you're unable to achieve primary closure, do you still use EthOss?
No. So I don't routinely place any grafting material into the third molar socket. I don't think there's any evidence for it. It will just heal by itself. In the case I've shown, it was a periodontally involved upper second molar, which is why I use EthOss, but it wasn't directly into the 8th socket. It was around the periodontally involved second molar to allow bone regeneration in that area. So no, I don't think there's evidence to place bone graft. I don't know, maybe someone's doing the research out there, but no, I don't routinely do it myself.
Okay. When using EthOss to fill a jump gap, are you still waiting for the E-cell EthOss to set prior to closing? Are we just trying to allow the last layer near the healing abutment to set? Especially, how does the deepest layer set if we aren't able to keep it dry?
Yeah, so the person who asked this question basically is basically uses it in the same way as me, probably, is that you pack the jump gap, if you like, with the EthOss, and because the most apical part of the jump gap you can't really reach, but yes, you try to put the gauze over the site, over the sockets, if you like, around the healing abutment. I still do that for about 3 minutes or so. And the area, the EthOss, it's closest to the healing abutment, closest to the gauze will set, and that is sufficient.
Yeah, I agree. Yeah.
Excellent. All right, I'll throw one last question in there for you. How predictable is EthOss when it comes to grafting outside of the bony envelope / contours?
EthOss is not predictable when grafting out with the bony envelope, and no graft is predictable in my hands. Grafting out with the bony envelope. It's one of those things where outside the bony envelope means bone wasn't there before. And if bone wasn't there before, you can't really defy Mother Nature and add bone. So I've don't get me wrong, I've tried. I think a lot of people have tried using various products to get greedy and want to add more bone to where bone wasn't used to be there. But yeah, I have not really successfully been able to add bone, bulks of bone with EthOss when natural bone did not exist before. So I don't know if Dr. Frank's magic hands can maybe kind of correct me here, but what's your experience?
Yeah, like atrophic cases, you kind of need a rigid framework to graft. Any graft, if you just put it on the bone, it's not going to work. Yeah, you almost need a rigid framework with bone that contains the graft material. Even so, sometimes the soft tissue will thin out and you get perforation. So yeah, it's a tricky procedure when you're grafting outside of the bony envelope. Yeah.
Okay, so on that note, I will say thank you once again. And if for the people that aren't on the EthOss case study Facebook group page, I strongly suggest that you go and join on that page. It is a peer-to-peer page, so it's not a marketing page or a sales page or anything like that. You do see the good, the bad, the ugly, and it's very interactive. So I do strongly suggest getting on that page. It is really, really good support. But I do want to extend our biggest thank you to these lovely gentlemen this evening, Dr. Michael and Dr. Frank. That was absolutely fantastic. The cases were wonderful. I'm sure I'm still going to get questions coming in after this evening about the cases. So anybody that does have any questions, please don't hesitate to send them through to us. We can still get them over and answered. But yeah, thank you guys so much for all of that. And we look forward to hearing from you again someday.
Thank you, Ashley. Thanks, Michael.
Thank you, Ashley. Thank you.
Thank you.